Okay, since we do have a quorum, are you going to get Joe, Chief?
But
Thank
we've
you.
got somebody in his office, I think.
Yeah. Okay.
We can go ahead.
Councilor Dobbins, would you please lead us with the invocation?
Father, thank you for this day. Thank you for the privilege of being here and our responsibility to represent our constituents, our entire nation, but also maybe ever be mindful that we are responsible to you in everything that we say and do. In Jesus' name we pray. Amen.
Okay, has everybody had a chance to go over their minutes? Oh, roll call. I'm sorry, Shirley.
Richard Shaw.
Present.
Mike Dobbins.
Here.
Bill England.
Honey.
Keith Austin.
Here.
Harley Bowser.
Here.
Joe Byrd. Sean Crittenden.
Honey.
Ricky Hargis.
Present.
Wanda Hatfield. Rex Jordan.
Here.
Dick Clay.
Honey.
Mike Shambaugh.
Here.
Theo Smith.
Here.
Denise Taylor. Here. Victoria Westwood. David Walkenstick. Brian Warren.
Thank you. Has everybody had a chance to review the minutes in our packet?
Second.
Motion been made and seconded. All those in favor say aye. Aye. Okay, all those opposed, same sign. Okay, reports. First up, Claremore Service Unit. Morning, George. Good morning.
That's good. Back in session.
Was it raining outside as of yet?
It was coming up, yes.
It is.
Yes.
Well, I'm glad we're inside then.
I think I told you a couple months ago we had one of our commissioned officers get picked for a national training for air evac. We've been really fortunate, and now we've had a second commissioned officer chosen for that training out of the entire country. So it's a pretty prestigious thing for these two individuals. So we're real happy about that and proud of them. We're working on chronic non-cancer pain management policies. They're set to take effect November 1. Dental clinic, we've added new chairs, new cabinetry, trying to redo and update the dental clinic. They've been hosting another extern from Roseman University. We lost a pharmacist to Yuma, Arizona. Lieutenant Commander Charity Earnhardt left us, took a job at the Yuma facility as the chief pharmacist there. We've hired our second biomed technician, which will get us back up to full speed there. And we're still waiting on the contractor to give us a start date for construction on the emergency room reconstruction. So, any questions?
Any questions? Yes, Councilor Shambaugh.
Sir, if you have a moment after the meeting, could I speak with you?
Sure. Absolutely.
Councilor Lay.
Thank you, Madam Chairman. Are you adding dentists or just rehabbing?
No, we're not adding any. We're just remodeling.
Thank you.
George, I have a question. When somebody makes an appeal for contract health through Claremore, is there a certain amount of time that elapses by before they come up for reconsideration? Or how is that weighed? How do you weigh that and balance that?
Well, they have 30 days to appeal, and as soon as we get the appeal letter, that goes to it's prepared and it goes to the review committee that following Tuesday, and they should have a letter in hand, or they should have a letter in hand by that following Friday. If you have had one or know of someone who has not heard back on an appeal, if you'll get with me and let me know, I can check on it.
Okay, I appreciate that
Sure.
information. Thank you. Does anybody have any further questions? I have one remodel. What's the remodeling going to cost? What's your budget for the remodeling at Claremore?
We had budgeted 1.2 million, and they came in, and it was going to actually be 1.6, and that'll add 4 exam rooms, 3 full exam rooms, a behavioral health room back there, 2 triage areas, a nursing station, and waiting area, 2 bathrooms, check-in, and what it'll do is in the back there where the emergency room is now, it'll all be completely self-contained back in the back.
That'll be nice.
Mhm.
Very good. Well, listen, thank you so much. Oh, Counselor Buzzard, yes.
George, what does the hospital do when you encounter a person that's, say, on drugs and they need to go to a rehab facility? How do you handle that?
If they come in and they're not in crisis and they're not suicidal or homicidal, they'd be referred over to behavioral health.
And then from there,
I don't know, that behavioral health belongs to you guys.
so you don't handle that
No,
up there at all?
No.
Okay, that's
no, sir.
that's what I was wondering. I didn't know
Okay.
if you had that or not.
No, we don't.
Okay.
Any further questions? George, thank you so much.
Thank you.
Okay, Cherokee Nation Health Service, Dr. Charles Graham. Good afternoon, Dr. Graham.
Good afternoon, everyone. You all had asked, and we sent out the recruitment report late last week to you, the most updated one. And as I mentioned last month too, 12 new physicians starting, an additional 6 by mid-September. And very, very excited about that. As always, Stephanie's here if there are any additional questions about that. Also, Counselor Dobbins talked to me beforehand and asked for a brief update on the provider health survey that we did. We've now presented that to all of the staff, the provider staff across the nation. We met with leadership first, all of medical leadership. Then we went to each of the clinics and presented it to each of them. And it was the exact same presentation that we provided to you all, council. And we answered questions for them and had discussions about various things. I did not have an opportunity to make it to every single one of those, but I went to as many of them as I could. They asked that I try to be there, and some of our leadership, Dr. Nolan, was at them as well. We are in the process right now of establishing a committee. There's going to be 8 people on it. We have not contacted those 8 people yet, but I'll tell you what our tentative current makeup is. We're going to have 8 providers that would make up the committee. 3 from the hospital, 5 from the clinics. 75% of those folks will be Cherokee. There will be 5 physicians and 4 advanced practitioner providers. And so a number of them are early in their career, and some of them are more senior in their career. So we have some that are early, some that are around mid-career, and some that are more senior in their career. No one from health administration will be on that committee. It's going to be entirely composed of individuals from either the hospital or the clinic. And I am going to be asking Dr. David Gann and Dr. Ashley Comerford if they will act as sort of resources to the group. So they'll be there to answer questions and things like that. And we're in the process of drafting a charge to that group right now. So that is the latest on the provider work group survey. I also have something I'd like to hand out and just go over with you briefly, if you don't mind. I think it's exciting. Might not be as exciting to you, but I'll wait till everybody gets it in their hands.
If you're excited, we're excited.
Kind of exciting, it really is. This is one of the things that we live for, to show you what we're doing, and it's what you wait on every month to hear about what we're doing. And so I wanted to, I had charged a small group of my staff to take a look at the current report that we give to council. And we've been giving that report to you now for many, many years in the same format. And so I challenged them to look at the way data is delivered today, especially at an executive level sort of dashboards and summaries, and come up with something that we could present to council. And what I'd like to do, I'm going to just run through each page very briefly and let you have this to look at. And for the next at least 6 months or so, I'd like to use this format, because part of this format is going to be changing every month. Part of it will stay the same, part of it will change with different data, and I think it'll be less dense for you to read, less material, but give you more highlights and summary level, executive level sort of statistics. So just to go over with you our thought process, and I really won't take long to do this, but on the front we'll always have a few high-level sorts of good things that happened, you know, that were going on that particular month. And so you'll see 4 to 5 or 6 bullets. Try to have some comments. A lot of times you don't hear the good things that organizations, community partners, or patients say to us. And 1 per month is really not that much, but at least start trying to let you hear some of the good things, the compliments that we get on a daily and monthly basis. Page 2 will be a rotating set of data. It won't have the same things in there, but it'll contain a lot of the materials that you've seen in our current report. But on some of that, we thought, well, we looked at data and said, do they need to see that every month, you know? Or is once a quarter or every other month sufficient to show certain data points? And so the data on this page, and sometimes it'll be 1 page, sometimes it might be a little longer. We will put in different facts about our health system, and you'll see rotating data in this part of the report. The next page, we know there are certain things that have always been important and that you'll always want to see every single month. And we do give you that recruitment report that Stephanie sent out, you know, late last week. But we'll also have we'll always try to keep our provider vacancy rate in there for you, so that you see that in addition to the report that you get offline. We know that contract health is extremely important as well. And so we have mixed the data up a little bit different look than you normally see. But you'll see, you know, 3/4 of a page dealing with contract health. You'll see our projected annual expense, our projected budget at year end, our referral rate. And then we gave you a little bit different look than that very dense spreadsheet that you sometimes see or have been seeing in our report. We did monthly visits by location and then monthly spend by location, so that you kind of get a look. And I know those of you that have delved into it, when you see that WWH has a bigger spend than it does visits, it's because a lot of the very significant referrals from all of your clinics go out of there. Things that either come through the ER or surgery referrals that come through there, and our surgery department decides they need to go somewhere else. But so we'll be showing that as a look for a while, and we may change up some of the graphics, you know, on a month-to-month basis or a quarterly basis to let you see a different look. On the next page, we always know patient visits and revenue have been important to you. So the top is the ambulatory care visits, really exactly the way you've always seen it. Just instead of, sometimes it's on an entire page. This time it's just 1/3 of a page. The next one is revenue, ambulatory revenue year to date, and we did 2017 and 18. WWH is down in the bottom left corner by itself, and then dental services we know are important, and we're showing you the same sort of data, just again trying to place all this on one page than on many. Then if you go to the last page, we've always reported to you things about our emergency department and urgent care, because you know, it's rare that somebody from all of your clinics might not visit our ED or urgent care over the course of a month or a year or whatever. So we've always reported that. We still have those there. We have our general surgery numbers, which we report to you, and then inpatient, number of inpatient days for that particular month. The bottom one, I envision that we would eventually have 5 data points on there. The reason that you only have 3 right now, what we are reporting to you right here is the RVUs, which is the new data that we're using, you know, for contracts and bonuses. And we're doing it by quarter, because that's how we are gathering it and then paying the bonuses out quarterly. And we just started that this year. But I envision that that when we have a fourth quarter and then a first quarter of the quarter and then a first quarter of the following year, you'll always have 5 data points so that you can see the first quarter of this new year compared to the first quarter of the prior year. And then we would just keep rolling that data forward. So I think our staff did a really good job. The proof will be what you all think about it, and I guess I would just ask that you have now, you know, our current report, the way we've always given it to you. Take a look at this one. I would like to use it over the next 6 months and see what you think about it. And again, that second page, and sometimes second and more, may be or will be rotating data. And maybe you'll see some of the same numbers every 3rd month or every 4th month. And sometimes you'll see some new graphics here and there, but we thought it would be good to, you know, show you a little bit different look at the data, show you a little higher level view of things, and I hope you like it. If you don't, I know you'll let me know about it in the month. And next month your report will be looking like the one I just handed out instead of the one that we gave you this month. And if there's anything important that you felt like we left out that you really want on there, then let us know and we'll try to integrate it.
Speaker Byrd.
Go ahead.
Councilor Taylor.
I would like to continue to see the diagnoses by clinic. I think that is very important to see what the top diagnoses are. That's a form that we're currently getting that is not in here. And
Are you okay with that quarterly, or would you like to see it? Because one of the things we could do is condense the data 3 months at a time, you know, so.
Let's try it quarterly,
okay.
And then if, and of course I'm sure you guys are looking at it all the time, but you can kind of see trends, and when something starts going up that's not normal, maybe something we need to be proactive on. And it doesn't change that much, hypertension, diabetes, I mean, it's typically, but sometimes you'll see an outlier in one clinic and it could be indicative of what's coming for the rest of us. So it is, I do feel like it's good information for us to have.
And it's good to know that that's a data point you like to see.
Yep.
So.
I like I like this format. I mean, it kind of separates, of course, the different departments and gives us some more data that we can read and understand. I like your recruitment department, how well they're doing. We all know that Dr. Jones always does his part and taking care of his department. I'd like to see a little bit more on the pharmacy department, different clinics, on how each clinic is performing. You know, who's doing the best job right now if we were going to rate those. Right now we don't have any idea. We're just saying they're doing okay. I'd like to see something written down on how they're performing. Okay, thank you, Madam Chair.
Councilor Austin?
On the contract health numbers, is Climate reflected in here?
Is what?
IHS, Climate. You've got you've got the office there.
Yeah.
Many patients, whichever. public fund there, and I don't know how to break that out of here.
Brett? Do you have a, since I don't have an answer, do you have a good answer?
Well, what was the question, Counselor?
Counselor Austin, could you repeat your question?
At Claremore IHS, we have a contract health office, and you know, it funds when after IHS has denied. So I know we're expending funds through that office, but I don't see how they're in here
I see. Okay.
under this graph.
They're not in here.
But we can add them in, right?
You're not surprised by that question, that answer.
No, I'm not.
If you ever see it, if it ever says BHC, we use, but it'll be in there next time. So I don't know why it's not, I don't.
That's why I didn't send this as the only report this month. And you know, the pharmacy information, you know, in the past we'd put some pharmacy graphics in there. I'll ask you the same question I asked Councilor Taylor. Is that something you want to see every month, or maybe once a quarter? Is like maybe we put diagnoses in there, and then pharmacy the next month, and then something else, and then start back again with diagnoses, and then pharmacy, and then, you know, we're trying to not flood you with data that doesn't change very much from month to month.
Quarterly would suffice.
Ms. Chair, I've actually had a continuing question here. Regarding the RVUs, you're just now really starting to see how that's working and all that. I would very much like it if you would be able to keep a close eye on if there's any particular type of provider who may not be being affected positively as much as they should be on that, because I kind of suspect we'll find that may be the case.
I'm absolutely watching that, and also watching for any unintended consequences, I'll call them, that may have started, you know, because we started doing it like this. So yes, sir, I will.
Thank you.
Councilor Lake.
Thank you, Madam Chair. You know, when I first looked at this, I didn't think I liked it, but I'm liking it more as I look at it. And I notice Oshaleta's still on the upswing in just about all areas.
And you got a new doc starting.
Well, and I was going to ask that question, so go ahead and tell me about it.
Stephanie, is it Monday?
She started this past Monday.
Monday, yes, this last Monday.
And the MD for NOADA starts, is that a done deal?
Yes.
Now,
He's going to be here Thursday to do some paperwork, and then be on the 26th. Or for today.
thank you. And so the panel,
Yes, sir.
I'm not sure what panel we called it, but how's that, do you have anything back?
No. We are just establishing it, and I gave you the makeup of what we're proposing, you know.
No, I mean the panel for the Hastings incident.
That panel. We have another call next Monday, I believe it is. I'm hoping, I don't know that that'll be the last call, but I'm hoping only maybe one more phone call after that before we are able to develop a final report.
And this new panel, this provider work group, I think you called it, we had something similar before. Was that expressly for the pay raise?
Yes, that was a compensation committee. This one is going to be, I'm having Dr. Gann and Dr. Comerford, who, as you know, helped us develop and analyze the data. I'm asking them to take a look at all the data that was in there and help me develop a charge to that committee. You know, what we would like to see from them. You know, one of them will be about communications, and, you know, there were other things on there. See what they want from administration or from the system. And so that's that committee. It'll take results from that survey and try to make recommendations to me, to health administration. And I'm going to use the word environment because it encompasses a whole lot of things, so that we can try to improve the environment that our healthcare providers work in, so that it's a place they want to come to work and that they want to stay to work.
I'm just sitting here thinking that other committee we lost two of the chairs, but hopefully that won't happen this time.
I hope so too.
Did we have a visit from Medicare 3 or 4 weeks ago?
Yes, we did. We had DNV come and visit us, which is our accrediting agency. And then just a couple of weeks ago, CMS did a follow-up based on our incident. The findings were very similar. They're never quite exactly the same, but they all fell in the same categories. And so we have, both of those things to provide us guidance also, besides the panel, the expert panel. We're switching around panels a lot. The expert panel that's looking at that, and things we can do to improve and try to make sure that it never happens again. We now have the guidance from DNV and from CMS findings, and that will help us a lot in the way of
What's CMS? I know it's short for
Centers for Medicare and Medicaid Services. Sorry, Centers for Medicare and Medicaid Services.
So did they find deficiencies, or
they found
how to get out of the problem?
Yeah, they found opportunities for improvement too, and they were around the similar things that DNV found, and if you classified them in services, they were in nursing services, as you would expect, pharmacy services, and infection control. Those 3 categories of areas, and we're going to be working on those. And actually, we already have. Whenever DNV came and made their findings, we started immediately working on them. They just came through and have found that we're not completely through working on all those things to get them up to where they need to be. But yes, we have now been visited by the 2 bodies, external bodies that would visit us, that are very unbiased about anything that they would say, that we need to do to improve our system. So those findings have been very helpful for us.
Did they give us any tools or motivation or complaints, or what? How did they handle it?
I don't know if they really give you any tools. Those tools are supposed to already be in our quality improvement department, our pharmacy department, our nursing department. All those departments have been working together to bring our policies up, in those areas where they're down. Any nurse or provider or other education that we need to be doing, either on policies or particular processes. And so, everyone really within our departments have been the ones that have put together the corrective action plans and the things that we need to do. The incentive they give you is you need to maintain your accreditation to maintain the ability to continue to bill. So that's a pretty strong incentive in and of itself there.
Dr. Grimm, did that affect our reimbursement in any way?
No, it has not.
Very good.
And in every, the way our accreditation works is DNV comes to us every year, but the accreditation cycle is every 3 years. And so on every 3rd year, it's a sort of more intense survey with more people and a little bit longer time frame. CMS had told everyone across the nation, and we had been told as well, that this particular year they were going to be doing validation surveys all over the nation. That they were kind of following both DNV and Joint Commission, which was the entity that we used to use, and that they would be doing validation surveys on various systems throughout the year. They've been doing that on other tribal health systems. They've been doing it on Indian health systems. They've been doing it on private systems. And so we had expected that CMS might come and visit us again visit us, not again, but visit us this year as just a validation survey to follow up anyway. And then when our incident occurred, that certainly spurred them on to come visit us, and so they they did their visit as well, and I guess I'm very pleased to say, you know, that every time they come, they have recommendations of things we can do to improve. That's the nature of their business and of ours. You know, DNV told us the incident was handled well. CMS said, you know, gave us their recommendations about things we could do to improve. And it's this way every time any accreditation body comes. As long as we make those changes, those corrections, and the next time they come they've been improved, then there is no jeopardy to our ability to bill or anything. And that's the way we've been doing things for, you know, 60 years or more, you know, depending on how long any of our facilities have been around. And we always are able to meet those, you know, opportunities for improvement or those deficiencies in certain standards that they point out. And I feel confident that we'll be able to do that this time too. I mean, they're very, you know, clear with you about the problems they find, and we have very, very good staff that are able to help us look at those things, put together corrective action plans, and it's up to me and our leadership to make sure that we carry those out. So.
Okay, Councilor Crittenden.
Yes, sir. Doctor, will you walk me through if a patient's ready for help, as far as rehab, they're having a substance abuse problem and they're ready? I know the first step is emergency room, right?
If they know they're ready and they can schedule an appointment, that's always good. But yes, they can come into the ER.
And I may have a few follow-up questions. I'm learning the process, and you've tried to help me all you could. But a lot of the folks and myself not real clear what happens after the initial visit. Can you kind of go over that?
You know, I can very quickly, but I think what I will do is that I'll have our behavioral health department put together a little small one-pager, for lack of a better word. It may not take a page, but it'll sort of tell you the normal process we would go through for a visit. You know, if somebody's already in our system and is wanting to do that, and then if they access us through the ER, that be, and then that way, you know, you kind of have that you can share with any of your constituents that want to know. But basically, if they come in and they're ready, we still do an assessment on them through our staff.
And is that 24 hours a day? We're able to
There's somebody on call from behavioral health 24 hours a day at our emergency department, yes. And then is sometimes the hard part is finding an available site. You know, we've had times in the past with people you've asked about too, where they were ready, and we had to tell them there's nowhere available right now. And sometimes it's that 3 days or 5 days that you wait to find a place that's open and that can take them, you know, for their kind of need, that you sometimes lose them, you know, if they are not watched closely, you know. But I'll have somebody write something, because I mean, I know it's confusing and it's a big issue.
Let me ask you.
It's a big issue.
All right, so we're checking to see availability.
Yes, sir.
What's some of the places that we're checking with?
I'll make sure that's on the list too. The sites, the primary sites that we use.
And just what, as far as Cherokee Nation, what can we improve on besides waiting for the availability of something else? Do you see, is the big hospital they're going to create some places where we can send these folks? I've heard, you know, and I know that's the way it is, and I confidence in you. I've heard waiting for a bed or not a bed, you know, like you said, and I know you're working on it. A couple of instances when they are ready. Mm-hmm. You know, the other night, the one you were helping me with, a few days later, family got him up there, and all of a sudden he wasn't ready. And so that, what the availability of beds, I know that's your big hurdle, but can Cherokee Nation
Right
do
now,
something about that?
we have on and off talked about it. You know, we have the Youth Regional Treatment Center that we run for all of Indian Health Service in this region, the Jack Brown Youth Regional Treatment Center that deals with alcohol and substance abuse. That's for a specific age group, and they will take people anytime when they have slots. It's usually a 90-day treatment period for that group. We don't have anything like that for adults that we run. We've talked about that on and off, about the ability to do an assessment of whether we could or should operate one of those. We aren't going to have that sort of capacity in our new facility. We are going to have a lot more behavioral health counselors, however. We did get outpatient behavioral health counselors, and we sometimes still have trouble getting, you know, if somebody wants to come in this week to get to see a behavioral health counselor, we can't always get them in that week. So it is going to help the access to care for outpatient sorts of services. What it'll do is it'll perhaps stimulate more, you know, residential or inpatient type care needs that we will still have to go to external sources and use CHS dollars to try to find. So that new facility is not going to help with the kind of thing that you're talking about. Hopefully it may prevent some of that if people are coming in to an outpatient counselor, you know, and able to start getting help that way. But when someone, you know, has to absolutely have, you know, either residential or inpatient, then the new services won't help that.
What percentage would you say that you visited about maybe an adult center? Is that gone very far at all, or just in the initial stages? I see it. You know, I'm just speaking for my district. What I see is it seems to be a growing problem, unfortunately, and I know with our lawsuits with the opioid, and I know the focus is on that right now. Look like it would go hand in hand with us, you know, sure enough focusing on an adult place, because I'm not pointing fingers at you or me or anyone, but it's a sad situation, like we've talked before, when the first step to getting treated is admitting you're ready. And, you know, those unfortunate cases. But yeah, I'd appreciate a little briefing on that, and that way I can explain where we are now, you know, and maybe tell them, you know, Dr. Grimm has told me that they're having conversations about what we may do in the future. But also had a question for pharmacy. If I guess the question is, I don't have to tell the whole scenario, but I have a pretty tech-savvy gentleman that was trying to get through the phone service and the online way to order a prescription or refill it, and he just couldn't make his way through it and called the pharmacy. He says somewhere in the message on the automated system that it says, if you can't get this to work, call the pharmacy. And I hadn't heard it myself, but said he got a hold of 2 different ladies, and they said they just absolutely couldn't make the order for him. And I guess the bottom line question is can we help someone? It kind of scares me that this tech-savvy guy couldn't make his way through. And, you know, if there's anyone less tech-savvy, can those folks answering those phones order for them? And
I think I actually talked to that gentleman myself too. And one of the individuals involved spoke with her. The second one haven't identified it yet. But he did have some problems, and we were having some intermediate issues with the IVR, which is the phone system. And so I contacted our IT pharmacist, who went in and made some changes, so hopefully that's improved. The computer portion of that, I never could really figure out with the gentleman what was going on with his orders. Other than, let's just say most of them were too soon for refill. But there was one particular one that he did want that I couldn't figure out either. But the answer to your question is yes. Yeah, we can help them and do and should.
And,
absolutely.
all right. And so was that conveyed to the ladies that told him that they
one
couldn't?
you bet. The other one I haven't figured out who the second person was. He talked
Well, thank you.
Thank you.
And I had one more question. Audiology. Now the big hospital there, we just have one right now, right?
Correct.
And what's the plans for audiology?
3 in the new one. So we'll triple our capacity.
Well, thank you. Thank you.
Counselor Buzzard.
Yes, and I think Sean, Council Curtin, had asked some of the questions I had about behavioral health. And I guess I was a little surprised a while ago when George said that we contract behavioral health out of Claremore. I didn't know that.
Yes, sir.
But I think there is a big need for this behavioral health, more management, because I've known the last month or so that I've talked to 2 people that were having trouble getting even accepted or even sent to a center. Once this young man was in a center, then he was going to get discharged and he needed a bed to go to. They couldn't find a bed, and I told him to get a hold of someone. I don't know who it was now, but I just think there's a need for us to have those facilities as far as Cherokee Nation goes. And I know you said a while ago you're looking into that now, so I think that's a good thing. I don't know if it's going to get better or going to get worse, but it's in a crisis stage right now with our young folks, and we need to provide something more for them.
And I'll make sure Claremore, if there's a process different at Claremore, I'll make sure it's on this little one-pager.
And I think that's good. I'm glad you're doing that, because a lot of times when they call me, I think I know where to send them to, but like at Jay, that's where I deal with Jay and those people up there. Sometimes we hit and miss their behavioral health at Jay, so that's an important thing, especially for our young citizens right now, and adults too.
It is becoming a bigger and bigger issue, and I will tell you that our behavioral health program, our health system, is looking at all the possible types of grants that there might be out there, particularly around the opioid issue right now. There's starting to be a lot of money coming out from different agencies about that, SAMHSA and others. And we're looking very, very closely at those, and I think we will end up bringing some money into our system. I feel very, very comfortable and confident in saying that. I don't know the dollar amount yet, but when we do, we'll be focusing more on that, the opioid, getting people off opioid addiction and things. It still doesn't make some of those other things go away, alcohol and other drugs, but we are constantly looking for things like that, and our behavioral health program has been very successful in the past at getting those kind of grants, and our whole youth program that we have, the HERO program, started by a large grant that we got, from SAMHSA, and then we had it over a number of years. That grant is now ended, but we are continuing to operate, that program because there was a huge need for it. We knew there was, and so I think we'll continue to do things like that.
Okay.
As of right now, we haven't been able to find any dollars to build, new inpatient facilities out there, but we're looking for everything we can.
And I think that's surely needed. I don't know if you're fully aware of, but the one pager that you talked about sending out to, the sooner the better, that you can get it out to be more beneficial to us. The other thing is I kind of like this report here, but I still like to know. I'm concerned with my district and the health centers in our district, and I'd like to know how many people we might have did breast screenings on there. I'd like to know, like the elder care, cancer, how many we did there. I think this report here gives a total overall, and you're not breaking it down like you did in the book. I like the way you did it in the book because I know what we were doing up there, whether if we were seeing an increase in cancer education, stuff like that. The other thing is on the public health educators. I like that report there because that deals with what I call pre-health benefits. I'm talking about our gardening programs, our walking program, smoking cessation, things like that. And I like to see those reports of what those people are doing. I
I had the same concern as we worked on this first draft and I talked to Lisa, who's over all those programs too. What can we do? You know, is there a way to either graphically or with a table maybe show something like that, like by facility, and we put smoking cessation here, or community garden, or some of the things that they do throughout the month, and fill it in like that, something so that it is quick and easy for you to look at. And if you want to target Jay, you just go straight there and look at that, but you can see the others too. So we're still, we put, one of the things I think we put in there, for their programs right off the bat here was the Wings membership. That's a very popular program out there in the community, and whenever things start happening with it, because of the funding sources that we use to do it, boy, we hear about it from a lot of people. And but I asked her the same thing as early as this morning when we were talking about another issue, that I wasn't totally happy with, like just 1, 2, or 3 facts every quarter, and is there something we can look at that will show you a little broader stroke about what's going on with public health? So I do have that concern too, Councilor.
I think the public health educators, they don't get a lot of publicity, but I think they do a lot of good things that we don't know about.
They do a lot of good stuff, you're right.
I think we just need to highlight some of them a little bit more and maybe bring up to the forefront. But anyway, back to the mental health issues. I think you're on the right track. I think we're on the right track of maybe getting a facility where we can send our people to now when they need it. And usually, and you probably know that, when a person goes, they're ready to go today, not 5 days or 10 days later.
I've seen it happen where you lose them in 5 days, and
Appreciate
then
you working
it's
on
another
it.
couple of months sometimes before they get ready.
Appreciate you. Thank you.
Councilor Shambaugh.
In regard to mental health, do our hospitals do EDOs?
Yes, but that's always a challenge in and of itself, probably worthy of discussion
Another time.
in and of itself. It's sometimes hard to find people to transport.
Sure. And that's what I was learning. So that's a timely process. But that's kind of a different deal than a voluntary. That's actually not a voluntary situation.
And we do those when necessary, yes.
Okay.
But I think we have the same troubles that all community hospitals do, And I wish there was a better and easier way to do it, too, for the patient's sake.
Councilor Walkingstick.
Thank you, Councilwoman. Is there Muskogee at 3 Rivers? Do they do same-day appointments over there?
Yes.
Okay. I had a constituent called up there, and they said they were short doctors or something like that. Are we short staffed over there, or
are we down there, Stephanie?
At 3 Rivers?
We had Dr. Lynn Stevens start 2 weeks ago. We're full at 3 Rivers now.
Are we? Okay.
We have 2 mid-levels that are coming on, one later this month, and then one as soon as she finishes getting her license will be on. So the 2 mid-levels is where we're short, but they're in the process of getting on right now.
Okay.
And those same-day appointments, usually at most facilities, it's, call in the morning, and they might have, depending on the size of the clinic, they might have a fair number, but they sometimes fill up pretty quickly, and then it's try to call tomorrow, or sort of our relief valve, if you will, for our system. And the further out you are, it's not as big a relief, but the relief valve is to go to urgent care, at Hastings, if it's...
Okay. All right. Thanks, Doc. Thank you, Chairwoman.
Councilor Crittenden.
Yeah, Doc, just to follow up, you said we're looking for money maybe to do some of those adult behavioral health facilities. Just while we're talking about it, what kind of money would you be looking for? I mean, amount-wise to do something like that?
The behavioral, I don't know the answer off the top of my head. First, let me say that. Right. But we'd ask the behavioral health program to look in, to put together a prospectus, if you will, of if we were to build a facility or renovate some facility, what would our staffing needs be, our ongoing costs, and if we were to take some place and do a renovation, what would that cost us too, to do something like that. And as of now, there's not a lot out grants for that sort of thing to do construction. What I will say is one of the things that Indian Health Service has gone out and asked tribes across the nation, and I serve on that. I chair that, actually, that board for Indian Health Service. It's called the Facility Appropriation Advisory Board. The last reauthorization of the Indian Health Care Improvement Act, the agency was given authorities that they had never had before for facilities. Used to be the only kind of facilities you could get money for through Congress, through Indian Health Service, were outpatient health centers, hospitals, quarters, for those places that were very isolated, housing, the youth regional treatment centers, and that might be it, those four kind of categories. In this new authorization, it gave us much broader authority for construction, and then we did a survey of Indian country and said, over the next 10 years, what are some of your greatest needs, you think? Inpatient behavioral health was right up there. So we have, the agency has the authority now, and we've shown Congress that data. The top 5 priorities, one of them were specialty health centers, kind of standalone specialty health centers that might serve a region. We're getting that basically in the new outpatient facility here in Tahlequah for ourselves. Anyway, there were a list of things ending with dialysis centers, and we had like about 10 or 12 or 15 things they could choose from, but we only took the top 5. We had our experts estimate the needs by region, and that was done just using specific statistical information by type of location, like a specialty center or an inpatient mental health center, inpatient behavioral health center. And so it didn't say Tahlequah needs one, or it said the Oklahoma region needs 4 of these or 3 of these. So Congress has that data now in their hands. It'll be interesting to see if we start getting any additional funding for some of these new kinds of authorities, because like I said, it used to be just clinics and hospitals and quarters and youth regional treatment centers, and now there are at least 5 additional sorts of facilities that we gave Congress information on in this report. It's a very interesting report on facilities. If anybody wants to see it, I'll bring you a copy next time. And it talks about, after a survey across the nation, what tribes said their greatest needs were going to be in the next decade. And we have to see if Congress comes through. I think because of the size of our population, we can certainly, if they do those sorts of things in the future based on population density, we ought to be right up there as far as competitiveness goes.
Are there any other tribes that have an adult facility?
I don't know off the top of my head. I can't imagine there's not a few out there that have done it. I've heard of 1 or 2 that have done some small ones, like just a few beds and things like that, so they have something on their reservation. But I couldn't honestly tell you the total number across the nation that have done anything like that. Not very many, not very many.
In the conversations, does that come up, maybe starting small?
In the conversations we've had, we were looking at taking a decent sized building, retrofitting it for a decent number of people, and I don't remember what it is, so I'm using a very vague term right now, but it wasn't going to be just 3 or 4 people. It was going to be much larger than that, and because we know we have a great need. We have really good relationships with a lot of these programs because we send a lot of people to them, and so whenever our folks call, and a lot of times whenever any of you call me about these kind of needs, I call the head of I'll call Dr. Nolan, I'll call, Mark Taylor, the head of our behavioral health programs, and say, we have somebody ready from this location, what can we do? And then they start looking, and trying to find something. And because we do send a lot of people to a lot of the ones that I will put a list down for you, if they have something or when they have something open up, they let us know, but sometimes, if they're ready today and we can't get it for 3 days, then everyone's disappointed, and sometimes you lose them too for a period of time. So
appreciate you getting that together, Doctor. Thank you. Thank you.
Dr. Graham, I believe we just have a few minutes left. I want to ask you about the Health Committee report you passed out On contract health, it says minus $9.2 million. Could you explain that to me, please, so I understand it better?
Okay, that means that if we continue at our current rate of spending, that we'll overspend our contract health budget by about $9.2 million. That's probably how you saw it. And I'll tell you that for many, many, many years, it's been that way. And so what we end up doing is we end up, setting aside a portion of our third-party revenue, and we end up using that to make up the difference. It's helped greatly whenever we got the 5% dividend funds. Other funds that we've gotten through Gen Fund or the council over time been very helpful. But to keep up the rate that sort of you all and our population has been accustomed to, I don't think there is anyone in the nation, I feel pretty darn comfortable saying that without even knowing, I don't think there's anyone in the nation that has a 97.6 or 8, can't tell without my glasses, we'll have to make that a little darker next time, a 97.8% approval rate of those things. And because of that, that's what you see. And we try throughout the year to send everything to anything internal that we can handle ourselves. We tell our doctors we tell the medical directors of each facility, look very closely at all the referrals. Are they things that you all can really do in-house? Was somebody busy one day and they made a referral, but it's something that you all can do in-house? And if you can, please try to do it in-house, because of that number you see right there. And so we do everything we can, but yes, that was in the other reports that we've shown you for many years, not quite as visible as that. That's why, we're trying to give you a new look, giving it to you sort of at an executive level and letting you see, bigger trends like that. But we kind of have fluctuated somewhere between 6 and 10 million overspend a year for quite a number of years.
Well, we all appreciate the great care that's rendered to our citizens through our health facilities. I want you to know that.
Thank you.
One last thing. I was made aware through an email that there is a lactation specialist now available for any Cherokee citizen who wants to schedule an appointment. Who would they call to get that appointment?
I'll find out.
Could they just
I'll have that for you next time on video here.
But we've got a growing baby here who needs some lactation help. Can I give them your number and you refer them?
Yes. The person that I know that told you that happens to not be sitting behind me today, or I'd get it for you right now. But how about I send it to Gail? She can get it out to all of you and then get it in the hands. That'd be good?
That sounds like a plan. Thank you. Are there any other questions? Any new business? Any announcements? Our next meeting is scheduled for Monday, September 10th at 1 p.m. And I'll take a motion to adjourn. So moved. All those in favor? Aye.